Let's see, share screen. Can everybody see my screen?
Yes, but we're not in full presenter mode.
What I'm worried about is if I go in for, since I'm on
oh, because you're remote. Yeah. Okay.
That's right. I'm remote, so we'll go this way because it's working. I worry if I go the other way, we'll have this, and then I would not. Is that better? I don't think that's better actually, but
I think it was better previously.
Okay, that's what I thought. Let's do this. All right. So today we're going to have our second lecture in PET, and this is more the PET 2 lecture we're going to have. What we're going to cover is the recent development in PET-CT and PET-MR, and then some of the applications of how this is, where this is going. So first, a couple of things on attenuation correction, because I think this is something we did not cover last time. The first thing is regarding how do we perform attenuation correction with PET-CT. So here's an example on the left of an image that is not correcting for attenuation. And on the right, the same image, well, the same part of the torso corrected for attenuation correction. And can anybody tell me what is the difference? How do you recognize any difference between those two? Well, I don't have it. Do we have the, do you usually use the chat, or how do we do to have people participate?
Usually having people chime in.
Okay, so if nobody had any ideas, I'll give you a hint. If you look at the skin on the left side, you'll see that it's hot, and on the right side, you'll see that it is not. Another thing that you may want to look out with attenuation correction versus non-attenuation correction is the lungs. If you look at the lungs here, they're hot, and here they're cold. So any areas that are not attenuated, they will appear as hot in the absence of attenuation correction, and then they will appear as cold once we correct for attenuation. So that's one good way to know what are we looking at. So if I look at, and this is, let's see if I can't do it in projector, so we're going to continue this way. This is supposed to be an animation, but it would have to project it in order for you to see it. Maybe if I do it this way. If I look at, if I had some detectors and let's say a tank of water, and in that tank of water I had eight sources that are all emitting positron photons. So they are annihilating 2 photons. I'm emitting 2 photons back to back from every one of those sources. Let's say from taking the first source, I will emit 1, 2, 3, 5, 6, you name it, photons. Some of those will be detected, some of those will be absorbed, and some of them will be attenuated and scattered, right? So if I look at the total I would get, say I would get 4, right, on this side. And if I emitted the same on the other side, I would get also some that will make it through to the detector, some that will scatter and not make it to the detector, some that will be attenuated and absorbed, and some that would be making it to the detector here. So 4 here and 4 here. So my probability of detection, if I emitted 4 on each side, would be probability on the left multiplied by probability on the right, and that would be 0.25, 1/8. I emitted 8 on each side, 16, I detected 4. And the coincidences are these ones. The other ones where I have 2 photons emitted at the same time being detected. So you see I got 2 out of 16, that's 0.25. So as you can see, that means that attenuation is going to be a big factor for us in PET, a lot more than what you saw in SPECT, because that probability of detection in SPECT would have been 1/2, whatever you got on this side when the detector was here, or on this side when the detector is here. In PET, because we have coincidence, and we have detection of 2 photons at the same time, well, we would require then, we would have a lot fewer photons being detected. And that's a big issue. So that means we always have to correct for attenuation in in PET. So let's look at that. What does that mean in terms of correction? If I look at here the length of my object, and if I had a photon, a positron annihilating with 2 photons emitting at this location, one would have to go through a short distance, the other would have to go through a much longer distance, right? If on the other hand, that activity was on the other side, I would have to go through a much longer distance on this side, but I would still have a smaller distance here. So in reality, what matters is not the location of the object for how much attenuation I get. What matters is what's the total length that I go through an attenuating object in order to get out of that object for the activity to be detected. So what that means is that the total attenuation for my coincidence depends on the total length of the line of response, not on the location within the object. And that's different than SPECT. Remember, in SPECT, the deeper we were in the object and the harder it was to detect the patient, because the photon, because that photon could be more attenuated. Whereas here we have 2 photons and one is going to be attenuated different than the other. And the total attenuation is going to depend on the total length. If you want to look at the proof for that, that's very simple. Let's say we have a volume of emission here. Then the probability of detection on 1 would be E minus mu x, and I would integrate that over x prime, say the depth on this side. The probability of detection on this side will be E minus mu a minus x, and since the probability of detection for 1 and 2 is the product, then I would have an integral from 0 to 1, the whole thing. X prime plus a minus x prime is a, so 0a mu x dx. So the probability, so the attenuation depends on the total thickness, the girth, if you will, your belt round, as opposed to where in the location is your activity. That is valuable because, yes, we will have to correct for attenuation. It's going to always be a big factor, but it's easier because you don't need to know where in the where did you emit your photon. What you need to know is what's the total length that the photon went through. In terms of scanning, the initial way this was done was very simplistic. The idea was you would start with a source of radioactivity that would emit 2 photons. One would be detected straight on this detector. The other would go through the object. So if there was no object, no patient, the attenuation I would get on one side and on the other would be the same. If, on the other hand, I have a patient here, I'm going to have fewer photons detected on this side compared to that side. So that would be the activity with no attenuation, I would call A naught. That would be the activity with attenuation, and A would be A naught times E minus mu x. I know A naught, I measure it here. I know A, I measure it here. And that's E minus mu x, therefore I can calculate the x, the mu that I have here and the thickness that I have. So that makes it pretty simple. The problem with this approach is that you'd have to have a rotating source, which is very slow, it takes time, it's clumsy. The good thing about this model is this approach is that your source has the same energy as your emission of positrons in the patient. So you have match of energy. So you don't have any difference in attenuation coefficients due to different energies. Remember that from one of our first lectures, the probability of interaction at a Compton scatter or as a photoelectric effect depends on the energy of the photons. The higher it is, the less photoelectric effect. So if I had a CT here, I would have a difference in differential attenuation than if I have positrons. If I have a positron emitter here, I'd have the same thing. All right. Another approach that has been used is just to do a calculated attenuation, meaning if you're doing a brain, it's all basically water. Just do a reconstruction without attenuation, draw a circle, assume that's water. If you want to be fancy, draw another one, assume that's bone, and then do a quick and dirty way of doing it. It works for the brain, not very accurate, or you can also do the same in the body with the transmission scan. A better approach that has been now used by all manufacturers is to implement a CT in addition to the PET. So instead of having a PET scanner, you get 2 scanners. You get a PET scanner in the front, a CT scanner in the front, a PET scanner in the back, and the patient would be coming this way. So you would scan first the patient on a CT, computed tomography with x-rays, get the attenuation map, and then you go into PET, and then you get your emission map on PET. And this is actually all scanners today in PET are PET-CT scanners. You don't have PET alone, unless it is a PET-MR, and that will be the subject of the next part of our discussion. So here's examples of different PET-CTs. What is important to remember is that the CT part of the PET-CT is not there alone only for looking at, here you go, that works. It's not only because we are trying to look at, we're trying to correct the attenuation. It is there because it provides us also actually with information about the attenuation distribution and the anatomical localization. So it's very important to remember the anatomical localization because PET, as we discussed in our first lecture, is a very sensitive modality, but it does not have a high spatial resolution. So that means that localization is very hard on PET. So here's an example that illustrates that. So for those of you who have grown up reading these books, these are books where you have Wally the Worm, and you need to find the worm in a scene where there are all sort of characters. In this case, you see there's a castle, there's park, there's buses, etc. And then you need to find Wally the Worm. And that is very much the same as what you would have with a CT scan, where you have a lot of spatial resolution of a lot of detail, anatomical details in the patient, but it's very hard to tell where the disease is, where the tumor is. Now, compare that to PET, and there you don't have the same spatial resolution. That's Wally the Worm you're looking for. And here what you're looking at is this worm. You'll see it very easily. It's right there. But it's very hard to tell what's around that worm. Is it surrounded by a car or by a policeman? And that's very much what we see in PET. Oh, here's our disease. But is this tumor has invaded the lung? Is it has invaded the pleura? How much of the tissues surrounding the tumor are involved or not? It's very hard to tell that from PET because the anatomic information is not there. So having a PET-CT allows you to have both of those. So in this case, you can see where Wally is, and in this case, you can see that the tumor is limited to the lung with no involvement with the pleura, so that's a good sign. All right, so this is the kind of application that we really now use with PET-CT, where we have at the same time the anatomical and the functional information taken together. All right. Okay, the next slide, the next part of the talk, I would like to cover 3 applications that are beyond PET-CT that have all had major impact now on the way we do our imaging. So let's start with the first one, which is the time of flight PET-CT. So what's the idea with time of flight? Remember when we talked about time of flight, when we talked about annihilation, we said that we have, maybe I'll come back to it in a second. We'll come back to this in a minute. We said that we have a positron annihilating with an electron, and then we have 2 photons emitted that are detected at the same time on 2 opposite detectors. But that's not the reality. The reality is that when you have 2 photons emitted from an annihilation, depending on where we are, so let's say we are here, this photon is going to go through this distance and be detected. And this photon has to go through all of this to be detected. And those are different distances. So one photon is going to be detected before the other. So the idea that the 2 photons are detected at the same time is not accurate. Actually, there's a difference in time of arrival. And that's what we're going to build on in our time of flight application. So I'll go back here. The very first time of flight was built actually by Philips in a commercial way. It was built by Philips. Note that this was a short axial field, 18 centimeters, and it was about 600 picoseconds of timing resolution. What does that mean? That means that you can detect 2 events, 2 photons on 2 separate detectors as 2 independent events that didn't arrive at the same time if they were separated by 600 picoseconds. So anything less than 600 picosecond means you're not, you don't discriminate between them in time. Anything greater than 600 picosecond, you can discriminate between them in time. All right. So that was 2006. In 2010, they improved to 500 picosecond. Siemens did the same, and GE did the same. GE had initially the Discovery 690, and now they have the Discovery molecular imaging DMI systems. Note again, these were in the 15 centimeters. Now all these scanners have gone in the axial field from 15 to 20 to 25, even 30, and then we're seeing more push towards 30 and 35 and even more in axial field to cover more of the body in one position. But again, if you look at the timing resolution, around 550 picoseconds, and they were showing improvements clearly in image quality. Here's time of flight versus non-time of flight. And then Siemens came also with the same thing, TrueV, and then the Vision later with an axial field of view 21 initially, then 25, and the timing resolution was 500 picoseconds. Now all Siemens reports timing resolutions in the 250 picoseconds, GE in the 350 picoseconds. So we are becoming much better at delineating where the event happened. What does that buy us? Here's what what I'm showing you here is a plot of body mass index, which is the weight of the patient divided by their height squared on the x-axis. On the y-axis, I'm showing you signal to noise ratio, meaning image quality. How good is the image? And you can see, actually the units for the y-axis is signal to noise ratio gain, meaning that's the signal to noise ratio you get with time of flight divided by the signal to noise ratio you get without time of flight. So you can see that in the worst case scenario, you get 1, there's no gain. And then as you go up, you have more and more gain. And note that as we get larger in terms of patient size, we have bigger gain. Now you saw last time that as the patient becomes larger, the image quality deteriorates because we have more attenuation, we have more scatter, and we have more randoms. So as the patient becomes larger, image quality is going to deteriorate. And yet, what we're seeing here is that as the patient becomes larger, the gain we get, the improvement we get with time of flight compared to non-time of flight goes up. And that's very good news. That means that we will be getting a boost where we need it, where we have the most a paucity of counts, a low number of counts we need to make up for it. So let me try to show you how that works. Let's go back to this. So we said we had these events that are being emitted, and those arrive at different times. These arrive at different times. And because my timing resolution is not perfect, I'm not going to have a perfect Dirac function of where they were emitted. I'm going to have a Gaussian towards around the location of emission. Now I'll say, most likely it's emitted here, probably a lot more likely to be emitted in this area than in this area, given my timing resolution. And for this one, the same way. How is that buying me any signal to noise ratio? Well, that buys me signal to noise ratio in 2 ways. The first one, if I didn't have these red Gaussians, if I back projected the along the whole entire line, both way, in both of those events, those 2 lines would intersect, right? And if the lines were to intersect, then I would correlate my 2 detections. So by having an area of emission that is more restricted of where I think I had my annihilation, I have decorrelation of those lines of response, which is very important when we're going to do our tomographic reconstruction, because we're going to do back projection along the whole line for every event. So that's 1. 2, instead of saying that the interaction happened somewhere here, the annihilation happened somewhere here, I'm saying it happened only here. Or instead of saying it's along this whole line, I'm saying it happened in this area. That buys me a lot in terms of counts, because if I had 100 of those, let's say in this area, instead of distributing those 100 along all the 1,000 pixels here and getting all the 100 pixels here and get only 1 count per pixel, I'm going to distribute them over 10 pixels here only. And my 100 counts will come 10 into each of those voxels. So I'll have a lot more counts per voxel in a smaller area and no counts elsewhere. And that's going to contribute to my signal to noise ratio. So in numbers, if I look at if I go from 600 picosecond to 300 picosecond, I can improve my signal resolution by a factor of 2. If I go from a patient that is 20 to a patient that is 40, I can improve almost by 2. So that's a very good sign. That means that as I get more better timing resolution, I will get better image quality. And as I get faster timing resolution, I can get also an improvement for larger patients. All right, so let's look at some images and see what does that buy us. This is a very good example. There's a lesion that you can see on the time of flight that is very hard to see on non-time of flight. And it is not this one here, it's this one here. Look at this lesion here, time of flight, non-time of flight. It's very hard to delineate the lesion here. It's very easy here. These are the lesions that we care about. Those are the ones that we call lesions with marginal detectability, meaning that the human eye, the observer, the radiologist, the medicine physician who's looking at these studies, they will have a hard time picking a lesion here. It's a lot easier to see it here. And that has a lot of implications because that means now we have a lesion that is distant from the initial disease, the primary tumor in the disease. So that means you have metastatic disease. That changes the stage of the patient. So that's one aspect where time of flight is going to improve image quality. Let's see how does that translate in other images. Here's another one. No time of flight, lesion in the lung here, time of flight, lesion in the lung here. And here's one, no time of flight and time of flight, lesion in the liver. All right, and then let's look at what does that buy us in terms of lesion detectability. What you're looking at here is the how good is your image quality. So the higher the bar, the better your image quality. And what you're looking at here is body mass index of 26 versus body mass index of more than 26. And you can see that for less than 26, the bars are higher than for more than 26. Of course, because image quality is better, it's thinner patients. But the gain you get with time of flight is small because the image quality is already good. When we go to large patients, you see that although the image quality has gone down, the improvement you have with time of flight is a lot greater than with non-time of flight. So the deterioration you had is a lot less than what you would have without time of flight. And that's very important. That means that we have something here that allows us to scan larger patients and keep the same image quality as with thin patients. All right, and this is just to show you one more thing that you can get with time of flight, which is that as the lesions are more and more conspicuous, meaning lesions that are very hard to detect, you will have better improvement on those than for lesions that are easy to detect. So here's 4 lesions, 6 to 1, 4 to 1, 3 to 1, 2 to 1. So the lesion is 6 times hotter than the background and it's 2 times hotter than the background. And you see that the gain you get in image quality, the ratio of image quality with time of flight versus non-time of flight, goes up as the lesions become less and less easy to detect. So that's another plus for time of flight. All right. Any questions on time of flight before we move to the next aspect, which is 4D PET? All right, no questions, then let's move to 4D PET. So for now, we've talked about you have a patient in a scanner, you perform a PET CT, and you get an image. The problem with this model is that your patient is moving during the time where you're scanning. So here's a lesion in the dome of the liver. It goes up and down. And you see how it makes the lesion oblong and not very easy to detect. Compared to other things in the scan, it's very hard to call this a lesion, not this. Okay. The reason for that is because you're scanning during the entire time as the patient is moving. So one thing you could do is you could say, well, I'm going to scan only when the patient is in a given position and stop scanning otherwise. So maybe when the patient has expired, is not breathing, is not inspiring, we'll scan. And then when they breathe, we'll stop. And then when they expire again, exhale again, we'll scan again. All right, that will improve our contrast because look, the lesion that was blurred here now is only here. And it's a lot more visible in terms of contrast compared to the liver. However, we paid with something else. What has deteriorated when we went from here to here? Just look at the liver here. What is worse here than here, in your opinion? Anybody? That's an easy one. Come on, guys.
The signal to noise ratio?
That's right. If you look at the noise here, this image is a lot noisier than this image. So the noise has been exacerbated, has increased. Why is that? Well, because I took only a portion of the scan. So I took only a portion of the counts, and therefore my noise is higher. In fact, if I had 1/9 of the frames, if I had 9 frames here, and I looked at 1 frame here only out of 9, I would have 1/9 of the count. The noise here will be square root of 9 equals 3 times higher here than it will be here. But it's a much better contrast. Look, I can see the lesion. So how do I do to do this? What do I use this for? I can use this for a lot of things. I can measure motion this way. I can delineate tumors very accurately if I want to do treatment planning. I can use that for dose calculation. I can use that for attenuation correction so that I would know exactly what is long and what is not long. And how do I do it? Well, the way to do it would be that you would have to acquire on CT your patient multiple times. So if you look here, you'll see that we're going to go through a trace here of acquisition, and we're going to have our CT on while the patient is breathing. So the patient is going to be breathing, and we have multiple CTs. We move the bed, and then we do that again, and we scan again multiple times as the patient is breathing so that we can capture the whole respiratory motion. So now we've captured the patient breathing, all right? And then we go to PET, and then we do the same. How does that incorporate together? Well, what I would do is, in this case, we would have an infrared camera here with a reflector. That's going up and down because the patient is breathing. That is going in, so I can see where I am in terms of movement, and I'm acquiring CTs at every one of those moments. So I hope this will work. Here's the CTs that I've acquired. Here's the monitoring I had from my infrared. I bring those two together, and then I can have I'm going to try to show you one. Oh, here we go. You see it here. Okay, now we can go back to, okay. Let's try it again. Maybe this time it'll work. Okay. So I've acquired, it's not coming in here, but I've acquired a cine of my patient. Yeah, here you go. I've acquired a cine of my patient. So not one scan, but multiple scans. Now, is that useful? Well, it depends on what's the motion. Here's one where, oops, sorry, let's go on this one. Here's one where there's barely any motion in the patient. Well, you can believe me, it's not moving. And here's one where there's quite a bit of motion in the patient. On this one, you can see how it's going up and down. Lesion is at the base of the lung and it's moving a lot. In the previous case, there was no motion. I'll do this maybe here. Oh. Okay. In this one, there was no motion in the patient. It was almost the same. So what that means is that depending on the location, I'm going to have a lot of motion, and it's very good to do gating or not. But a priori, I don't know which ones are the ones where there's motion, which ones there are not. So I'm going to have to do it for all of them. So if you're going to do gating, you're going to have to do it for all of them. But it's very valuable because I'll show you an example here. Here's an example where the lesion was considered to have responded to chemo. There was no problem here. There was SUV of 2. Whereas when the same patient was done in 4D PET, meaning doing respiratory gating and acquiring multiple frames on CT and PET, that lesion doubled in SUV. SUV is the intensity of uptake of the tumor. So that tumor is 2 times more aggressive than this one, and yet it's exactly the same tumor. It's just the motion that was corrected with gating. Here's another example. Here's a lesion post-chemo that was read as responding to induced chemo. There was positive response. That very same patient was considered non-responding when a 4D PET-CT was performed and motion was corrected. So you can see that this can have dramatic effects on not just image quality, but also on the outcome of the scan and outcome actually of the patient, whether we consider them responding or whether we switch them to another treatment. So it's not a small innocent thing, and that's partially why several groups work really hard on doing this in the clinic, because it has a lot of impact. And here's one last illustration. This one is in delineating a tumor. So that GTV means gross target volume. That's the contour of tumor that the radiation oncologist delineated in blue when they delineate on a PET-CT where there was a regular PET-CT done. In green, when they delineated tumor on a 4D PET-CT, so one where there was a respiratory gating done. And you can see that there's a dramatic difference. There's no point in having a very accurate treatment plan if that's what you're going to treat, because you're not treating the tumor. You can see it here in chroma as well. So we discussed so far time of flight PET-CT. We talked about 4D PET-CT. Now we're going to talk about PET-MR. Any questions? All right, so let's move to PET-MR. We saw that there was an issue with PET-CT that had to do with the fact that you acquire your PET, then you acquire your CT, and that the CT was very fast, the PET was a lot longer, so you didn't have the same time resolution on both PET and CT. So the idea is, what if we had a PET and an MR together, acquired at the same time? What would that buy us? Well, that would buy you a lot of things, because your PET system is highly sensitive. It can detect very small amounts of activity, of concentrations, whereas your MR system is a lot less sensitive. But your MR system is non-ionizing, and it has a very good timing resolution and a very good soft tissue contrast, something your CT doesn't have. So if you had your PET and your MR together, you would have the best of both worlds. It took a long time to build PET-MR scanners, and that is not because people are lazy and they weren't working on it. It's simply because it's a much more complex physics problem to solve, an engineering problem to solve, than it was for PET-CT. The reason for that is, as you remember from Johan's lecture last week, in PET-CT we have crystals here, light, so photons are coming this way, absorbed, light photon is propagated here, and then it hits a photomultiplier tube where it's amplified, and basically that's a vacuum tube where you have electrons that are being amplified, more and more and more electrons, and then they are read at the end. Whereas with if you put that in a PET-CT, it's fine, you can detect the signal. If you put that in a PET-MR, all those electrons in the vacuum are going to go all in one direction. So you're not going to have a signal. So you need to have a solid state detector here that is going to allow you to detect those photons and then amplify them without ever going into electrons in vacuum, having electrons in solid directly being detected. And that's what the solid state detector does. That's what the avalanche photodiode does. One thing I'd like to draw your attention to is the aspect ratio. This crystal is the same as this crystal. So this is 2 centimeters. This is 2 centimeters. So this here is about 8 centimeters, 10 centimeters, and this here is about 5 millimeters. So this together is a lot thinner, less deep than this. That's very important, because then that allows you to put the whole thing into a magnet and then see something. Again, the first manufacturer who built this was Philips. They had a washer dryer, they had a PET-CT, a PET-CT system, and then a PET-MR system, a PET-CT system and an MR, sorry. And then the first The first avalanche photodiode developed went into the Siemens system that I'll show you in a minute, which is photodiodes are very compact, as I said, they're very thin, a lot thinner, but the problem is they're slow. So you cannot do time of flight PET with APD PET MRs. You have a solid state detector with a junction PN, a PN junction where the light comes in, and then that junction gets you your electric signal out without going through any vacuum. All right. This is the Siemens PET MR, where you could see on this drawing the location of the PET detectors. They're right here in blue. So they are smacked right between the RF body coil and the gradient coil. So you are detecting your MR signal at the very same time you're detecting your PET signal. All right. Now, we said the main issue with the avalanche photodiodes is that they're slow, therefore you cannot get, you're not able to determine differences in time of arrival to do time of flight. So the second generation of detectors was the silicon photomultipliers. Now we're going to be operating in Geiger mode. It's going to be very fast, and we're going to have a signal of 0 or all or nothing. All if we hit a cell, nothing if we have no cells that are hit by the photon. So we can get information about energy in that case. Here's an example of a silicon PM. So a PM is probably, say, 3 by 3 centimeters. A silicon in a 3 by 3 centimeter, you have 1 PM. A silicon PM, a digital PM, in a 3 by 3, you have 10,000 silicon PMs. So you can see that there's a dramatic reduction. Oh, I'm sorry about this. I'm not sure why it's doing this. There's a dramatic reduction in the size of the detectors. We're here now at less than a millimeter for each cell, far less than a millimeter. And since we're counting in all or none, we can have information about the energy, so we can do time of flight PET MR. That was the second generation of scanners that GE brought in, the time of flight PET MR, where now we would have simultaneous PET MR, and we can use these things we did with time of flight. Remember when we looked at time of flight, we had better signal to noise ratio. You can see this here. This is the time of flight PET MR, non-time of flight PET MR. You can see that this lesion is much better detected here than it is here. And same thing with patients. Here's a patient where you can look at the mediastinal lymph node. It's much better delineated than on non-time of flight with CT, time of flight PET MR. Same thing in the spinal cord. Look at the spinal cord details here compared to here. All right. So now we got the best of both worlds. We have time of flight and we have PET MR. What can we do with that? Well, remember that with PET MR, now we're talking about having MR and PET at the same time. So any motion of the patient on MR is detected on PET and vice versa. So we could correct for motion that way. So let's see, how would we do that? Oh, sorry. I'll show you that in a second. Sorry, there was one thing I want to show you, one more thing. The other thing we can do with PET MR is that we have also a better soft tissue contrast. And that would allow us to see lesions much better on MR than on CT. That part is not an improvement on the PET side, it's an improvement on the MR side, but it still serves the joint, the multimodality image that we have from the two together. So here's some examples of what that looks like. Let's start with this one. Here's a patient who had a known melanoma and who was in the middle of her ovulatory cycle. And we saw on the PET CT, there was a signal here, there was a hot lesion here. It wasn't, we weren't sure, I'm sorry, it wasn't lesion. We weren't sure, there was a hot signal. We weren't sure if this is an ovary or if this is a metastasis. On CT, you can see here there's something, but it's very hard to tell. And the reason is, as I said earlier, CT has a very low, is not as good in terms of soft tissue contrast. So can we see something better with MR, with PET MR? Let's see. So now we go to PET MR, and now we look and we see that, oh, well, here's the ovary, and you can see the cortical rim. And here's the signal we saw on this side here. And this is GADO-enhanced signal. So that is not an ovary. This is actually metastasis. So that tells us that we have a metastasis here in this location that is due to metastasis from the melanoma that was not detected on CT. So that gives you a sense of the improvement in image soft tissue contrast. Look at this versus this. All right. That's one piece of gain. And you can apply this to multiple applications. I'm not going to go to all of them now because we will have a session with this, with Thomas Eng talking about the clinical applications. But here's an example. Let me show you this one. This is a better one. I'll show you one or two examples of where there's clearly an improvement with one compared to the other. Let's do this one here. So here's an example of a neuroblastoma. These are patients that would come and would have two scans. They would have first an MR, and then you see something. And then if you see something, then you have to do a PET in order to delineate if this is, what is the signal. In between those, these are usually pediatric patients. In between those, they'll go home and come back. So you can imagine the worry of the family when they're away for, before coming back and they don't know if they have a lesion or not. And then you can imagine how hard it is for the patient because, especially for young patients, you have to sedate them. So we would have to sedate them twice. Once for MR, once for PET. Whereas if you have a PET MR, you do the two at the same time. And in this case, you can see that in this area, there is actually a bone marrow metastasis. So this is real disease. Okay, I'm going to go through this one. I'm going to move to motion. So the key we said was that we have the PET and the MR acquired together. If you remember this slide, we looked at it earlier. We had a lesion in the lung, a lesion in the base of in the dome of the liver. And because the patient was moving, we were blurred. And then when we corrected for motion, we had a much sharper in focus, higher contrast image. So the problem with this, and that's what we called the 4D PET gated PET, 4D PET CT. We looked at several examples 20 minutes ago. But the problem with this, and as Penina mentioned, was that, well, yeah, but here you have a lot higher noise because you have fewer counts. So the question is, can I improve the contrast without sacrificing the noise so that I can improve my signal to noise ratio and not just improve my contrast, meaning improve my contrast, but don't deteriorate my noise? And the answer is yes. And this is something that is not only in oncology application where you see motion like this, you can have that in cardiac applications where you can see, for example, a patient's heart coming from one area to another, or a patient's liver falling into lung because the CT was acquired at a different time than the PET. This was acquired in 30 seconds or 20 seconds. This was acquired in 3 minutes, and then the location of the liver is not the same. And that will cause artifacts. And I think you saw some of those with the Owen last time. Here's an example of the heart, where as the patient is breathing, part of the heart, the anterolateral wall, falls into the lung. So you see this area, we say, well, that's not attenuated because it's in the lung. So we don't correct for it. And here you go. Whereas that actually, when it's corrected for motion, you see that it's in the heart, and then you get this. There's a big difference between those two. This means you have ischemia. They're going to take you to the cath lab. This, you're fine, you can go home. So as a patient, you can think about the difference that there is between this and this. It's huge. All right, so how would we do this? Well, the way to do this with a PET MR is very straightforward, actually. What you have to do is measure the motion on the MR side, because you have the motion on the MR, you're acquiring the MR all the time, and then incorporate that motion into your PET reconstruction. So instead of acquiring one MR, I'm acquiring many MRs. I'm going to transform them into attenuation maps. And then I'm going to measure a movement between all of those, a motion field, and then I will reconstruct that motion field. Here's an example of how this would work. Here's an example of a primate that is breathing. You can see the MR, and you can see at one point you see a grid here, and then the grid disappears. This is what we call a gated, a tagged study. We impregnate a magnetization on the tissue, and we look at that magnetization being deformed. And as it's being deformed, we can measure the motion field. And here's the corresponding PET. And you can see that the monkey is breathing. It's going up and down. And here's what that gets you in terms of motion field. Those arrows are telling you how this voxel is moving at a given time. If you look at a different time, it would be like this, then back like this, and back up. All right? What does that do to us in terms of image quality? This is our PET CT. I want you to look at those two lesions here and to look at this area for noise. So if this becomes grainy, it's noisy. If these are not visible, the contrast is low. There are two lesions here. This is our PET CT. This is our gated 4D PET CT, the one we did earlier when you have multiple acquisitions. That's what you would get. And you can see here, two lesions that are much better delineated than here, so better contrast. But look at the noise is higher because we have only a subset of the counts that we had here in the case of the uncorrected. So we gained in terms of contrast, but we paid a price in terms of noise. Here's what we get when we do motion correction with PET-MR. So now we are acquiring all those fields and then we're reconstructing all of them together into one frame. Here's the noise, here's the background, same as here. Here are the lesions, same as here. So we got the best of both worlds. And to convince yourself of this, you can look here. This is your reference image that we acquired for 6 times longer, but with gating here. So basically we acquired only in one position, but we acquired for 6 times longer. So we'd have enough counts to have very low noise. So we'd have high contrast and high noise. And you see that those two images are almost identical. The contrast is the same and the noise is almost the same. So you've gained a factor of 6 in terms of the time of imaging to get the same image quality. All right, and that's very important also in terms of resolution, because look at here what's happening when you look at those two lesions, the same two lesions, and when you look at a profile through them. So we're looking at activity through the lesions. It goes up and down. Here's that profile when you don't correct for motion, meaning when you're here, that's what the profile looks like. Here's the same profile when you correct for motion. You see how sharp the delineation is. There's a big difference here between motion correction and no motion correction. All right, and here's finally an example in a patient. Here what we have is a patient that is breathing. Here's the MR and in real time, and here's the PET that is acquired in real time. What is that bias in terms of image quality? Well, let's look at the second image here. Here's your PET CT, no motion correction. You just acquired for 3-4 minutes, 5 minutes, and then that's your image. Not noisy. You see it's low noise because required for a long time. And the lesion looks like any lesion, you know, nothing to write home about. I want you to look at this here, the bottom right. Very same study, very same patient. But now we've corrected for motion with MR, and you could see that the core, the center of this tumor is hypoxic. It's less hot than the rest of the tumor. That's what happens in tumors as they grow, and that hypoxic core will tend to be a lot more radioresistant, meaning as you treat the patient, that is an area that will resist radiation more than the area that is hot. So when if I know that there is this, then I will boost the dose to the core of the tumor compared to the periphery of the tumor. So again, you see, this is not just a pretty image. The value here is that can help me define where to distribute where to deliver my radiation dose, given what the tumor looks like. All right. Any questions so far? All right, so the second example I'm going to show you is going to be an example now, again, where we're going to be guiding, therapy, radiation therapy. But here what we're going to look at is, can we have a better contour of where we treat? And can we tell if a lesion has responded or not? Those are things we cannot do necessarily with MR alone or with CT alone, but with PET-MR we can. So let me show you an example. Here's a tumor, and what I'm showing you here is multiple radiation oncologists who drew a contour around the tumor. You see that it's quite variable and it's quite big. And some will treat only this, and some will include this part. So the question is, can we help the radiation oncologist delineate really where the lesion is? And the answer is yes. Here's an example. Here's one. Here's a sarcoma. You can see here all of this is enhancing on MR. So according to MR, all of this would have to be treated because there's peritumoral edema as well as tumor. Here's what the PET looked like. And on the PET, you see that only this area here is hot and the rest is not. So if you were following PET, you would treat this. If you're following MR, you treat this. And let's see what is right. Well, we take the tumor out, we look, and we see that here you go. That's where the tumor is. And this was not tumor to cells, no tissue. So tells you, well, you could reduce your volume of treatment. And that would be very valuable because then you can put more dose in a smaller area and kill more of the tumor cells. And then we can also look at, after treatment, we can tell if a patient is responding or not if we have a PET-MR. Why? Because when you see a signal after PET-MR, you don't know on PET if it's a tumor or not. Because once you treated the patient, the tumor is going to be inflamed, the tissues are going to be inflamed, and it's very hard to tell what is tumor and what is inflamed cells. So PET is not going to guide you, but PET will tell you where to look. And then if you have an MR, you could look at spectroscopy and confirm that this area is a tumor, that's where the tumor was. This area is normal, that's the contralateral side. And this area in question has the same signature as the healthy tissue. So that's not a tumor. And sure enough, following the patient over time, demonstrated that wasn't a tumor. So that allows us to follow the patient over time with a PET-MR and determine whether or not they should come back for treatment or not without any need for surgery. All right. So let me show you now some examples of what we can do if we have a PET and MR in imaging the heart. And the application I'm going to show you is one where we're looking at membrane potential. So membrane potential is an area that Felicitas is working in our lab, where we look at basically the voltage inside the cell versus outside the cell. That voltage, there's a difference in voltage. That's the whole electric battery of life, and it is something that is very affected in disease, and it's very conserved and preserved in normal conditions. So how can I measure that? Well, if I inject a cationic probe, a probe that is charged, it's going to distribute inside and outside the cell according to the concentration of charges. So if I look at the ratio of the tracer that I've put in inside and outside the cell, it will tell me what's the voltage difference is, what's the membrane potential is across this membrane. Great. But if I want to do that, I need to have, we'll skip this. If I want to do that, I need to know what the extracellular space is, because I need to quantify that. And that is something I can measure only with MR. So if I have a PET-MR, I can measure at the same time the extracellular space with T1 mapping and the membrane potential with PET. And I can get a number that tells me what's the voltage in the myocardium. So what you're looking at here is negative numbers in millivolts. These are not arbitrary units. These are not uptake values. These are the membrane potential in millivolts in the myocardium. This is measured non-invasively with a PET-MR. And this is a nice thing to look at. If you see here, if you look here, right in the middle of the heart, this is the heart here, right? You see it here. This is the endocardium, the epicardium. This is the apex of the heart. Right in the middle here, this is the endocardium. I'm sorry, endocardium is here, epicardium is here. And right in the middle of the two, right here, you see there's a scar. There's an area that is alive and everything around it is dead. That's a very good model of conductance that causes arrhythmias. And with PET, we can detect that and know which areas to treat. So that's very valuable when you're going to be mapping the condition of a patient, and you can measure it only with PET-MR. All right, and here's an example of a patient study of the heart with PET-MR. I'm going to show you one last example of where PET-MR can be very helpful in the brain, because obviously the brain is one of the areas that is the most useful. We do MR all the time in the brain. We do PET in the brain. You can do them together. Let's see what you can buy with that. And here the application I'm going to show you is going to be one in aging. So we're looking at the population as the population becomes older and older. All right? And as the patient, so this is this axis, this is life. We're all getting older. As we get older, you see that our risk of dementia goes up, right? Whether it's low risk or high risk, at one point, you'll be there. That's our clinical risk of dementia. But I could look also at other things over time and see, for example, what's the accumulation of amyloid in my brain over time? And you see how it goes up and then plateaus. What's the accumulation of tau in my brain? And you see that it also goes up and then it plateaus. And the question is, could I measure these here when they are starting to increase here in this time, in this area, instead of when I get here, because I know here there's a problem because I'm demented, but I would like, before I become demented, if I could detect here a change in tau and amyloid in this regime, it would allow me to use any drugs being developed for early treatment in an effective manner, because these drugs are not going to work if you are here. There are no more cells to cure. You want to act here. So we're very lucky in PET that there's several molecules now that have been recently developed and are actively used that track tau, the tau protein in the brain. So I'll show you some examples of how that works. Here's the first. This is a slice of brain, so obviously it's ex vivo. We're doing immunohistochemistry, and you can see here the staining for 88, which is the hyperphosphorylated tau. That's exactly what we're trying to measure, but that's ex vivo in a slice. And this is in the same slice, but now not with immunohistochemistry, so it's not in a microscope. This is on a gamma camera, on a PET scanner. This is, you put in front of the PET scanner, or you do autoradiography, so you put a detector in front of it. After incubating it with radioactive F18 fluoro tau superior, so a tau tracer. And you can see the same thing as here, look. So we have an in vivo way of measuring the same thing as with immunohistochemistry. What is that bias? Well, take a look here. Here's a normal patient. Here's an Alzheimer patient. And here's someone in the, like older on, starting on the way to be, starting having cognitive impairments. Here's somebody who's very mildly cognitively impaired, and here's an Alzheimer patient. And if you look over time, you see how you have more and more tau in these areas. Like in the, these are very key areas in the brain, in the neocortex, in the temporal neocortex, that is where tau will accumulate as the patient becomes more and more demented. So you see you have a gradation over time, same thing with amyloid. So you could scan a patient at a given time and tell where are they on their path being normal or not. And here's one example. Here's I'm showing you a gradation. So normal controls, prodromal AD, mild cognitively impaired patients, and then Alzheimer patient. You see how you have more and more. Okay, so that's a very useful way with PET-MR, where you have the MR and you have the PET. I'm gonna skip this, and I'm gonna go, I hope I have the next one. No, so I'm gonna show you, the last example I'm gonna show you is this. This is now, what we're gonna do here is we're gonna use the PET, we're gonna use the MR as a prior in the PET reconstruction, meaning I know I have CSF here, I shouldn't have activity. I know I have bone here, I shouldn't have activity. I know I have here a transition between two material, between CSF and gray matter, then gray matter and white matter. I can model all of that in my PET reconstruction using patches, and I will get something like this. I will get something, sorry, like this, instead of getting something like this. So this is my PET. This is my PET with an MR anatomical prior. And I hope you can see here how nicely we improve on spatial resolution compared to here. All right, here's another example. And you can see here again how you can improve in these areas, and you don't improve elsewhere because there's no information elsewhere. What is again very important with PET-MR is that not only do you improve the image quality, but if you look at the correlation between our imaging and the clinical diagnosis in terms of neurological diagnosis, our correlation is very poor. And when we use PET-MR, when using the MR anatomical prior with a PET-MR reconstruction, that correlation goes significantly higher. It goes by 40%. So in all regions. So that's very valuable because that means we are getting a better clinical diagnosis using those images than what we had without. All right. And the last example I'll show you is from subjects who play in contact sports, like football players. What I'm showing you here are a signal from tau that shows you traumatic brain injury in areas of uptake where there's been injury. And here, versus if you look here in normal controls, no uptake. And if I have a PET-MR, I can look at tractography at the same time. I look at diffusion tensor imaging, so I can see both where is tau accumulating and what's the impact on white matter bundles. So here's white matter destruction in this area where I have uptake, and here's preserved white matter where I have no uptake. So it's very valuable when I have both of them at the same time. All right, and here's a very nice example of, you see the thinning in the white matter in this area, we have concentrated activity, and then no thinning in this area where you have no uptake. All right, so I think that's it. I hope this gives you a sense of recent developments in PET-CT and PET-MR and where we are going with these applications. So as you can see, everything we saw so far, both in terms of corrections, as well as in terms of instrumentation, takes us into the direction of higher spatial resolution, improved signal-to-noise ratio, and all of those are for very specific clinical tasks, not just for having a prettier image, but because there's value in obtaining these images for the clinical diagnosis we're trying to make. So I think that concludes my talk. I am happy to take any questions you may have. We have, I think, a little time for discussion. Right? Am I correct, Moses?
Yeah, we've got 10 minutes.
So, thoughts? And if people could turn their videos, if they're comfortable with that, would be great, so I can see who's saying what. So any questions on PET-CT or PET-MR or PET, or even on the last lecture in PET that you had last time? We can cover any of those, because I think this is our last PET lecture. Okay, well, if we have no questions, you can get